So the topic of today's talk is management of stable ischemic heart disease, and I feel that this is a very pertinent topic to all of us as physicians, especially those of us on the front lines within primary care, as you are really going to be the first line for the majority of these patients in terms of their longitudinal care and follow-up. All right, so the background, sort of the goals of this talk are really to discuss the clinical definition of stable ischemic heart disease, and sort of I broke it down into stratification and medical therapy. So in terms of stratification, we'll discuss the importance of stratification, discuss the different modalities for risk stratification, also appreciating the differences in the specific sensitivities and specificity of each study, and also discussing the benefits to an invasive ischemic evaluation as it relates to risk stratification. In regards to medical therapy, we'll understand and define the goals of medical therapy in our patients. We'll review some of the primary data behind our currently accepted ischemic heart disease guidelines, and we'll briefly review some of the novel therapeutics which have arrived on the scene within the past couple of years. So for background, so stable ischemic heart disease, it basically includes all conditions that result in a chronic or repetitive mismatch between myocardial oxygen supply and demand. So this is sort of the basic pathophysiologic level. Typically, whenever we think of oxygen supply and demand, we think of coronary ischemia, epicardial coronary ischemia, and that remains sort of the dominant presentation for these patients. So epicardial atherosclerotic obstruction, microvascular disease, which is basically disease that's confined to the small vessels, which we can't readily see on angiography. Though we do have ways in the cath lab to make this diagnosis, it is not widely available just yet. Coronary vasospasm, which typically tends to happen in arteries that are already mildly abnormal, but that typically results in a mismatch of supply and demand. Congenital anomalies, and these include coronary artery anomalies, anomalous origin of coronary arteries, and there are certain conditions where the course of the coronary artery passes through certain structures, and this extrinsic compression can create dynamic ischemia, and vascular injury. And vascular injury is just sort of a waste bucket term. It includes repetitive inflammation, anything that really injures the vascular endothelium and causes issues with relaxation and constriction. Angina is a classic symptom of stable ischemic heart disease, but it's important to recognize that patients can present with a wide range of symptoms, including shortness of breath, heart failure clinically, or even arrhythmias. And important to note that stable ischemic heart disease does not refer to patients with new chest pain at rest, crescendo angina, or a change in the nature of angina, or biomarker positive. These patients are in a different sort of physiologic mechanism. These are patients that we would describe as unstable or on the spectrum. So in terms of stratification, goals of risk stratification are to prevent or the prevention of morbidity and mortality for our patients. This important distinguishes from ASCVD risk, which a lot of our primary care physicians do already. This is primary prevention. So when we talk about risk stratification, we're talking about patients with established coronary disease. We're trying to reduce the risk of recurrent events. ASCVD, we're taking into account potential risk factors in the way of diabetes, hypertension, everything but coronary disease to estimate the risk of developing these conditions down the line. For risk stratification, our categories that we have generally defined are based on mortality rate. So less than 1% is considered low risk, and greater than 3% is considered high risk. Anything in between is intermediate. And you'll see that this distinction is important because it affects how we manage our patients and obviously their long-term outcomes. So in risk stratification, a multimodality approach is usually recommended, and this will typically include obviously a clinical evaluation and analysis of comorbid risk factors. Functional capacity evaluation in the way of a stress test is pretty much always indicated for these patients. ventricular function assessment with an echo or cardiac MRI or a MUGA study, and coronary anatomy. Coronary anatomy, as we'll discuss, can be defined classically through angiography, but increasingly we have non-invasive ways to evaluate the coronary bed with coronary CT. So patients obviously require a personalized approach to each of the above, but typically the most successful approach to risk stratification will incorporate 1, 2, or even 3 of these different modalities in order to get the best outcome for patients. So in terms of functional studies, so this list here shows the different types of stress tests that we currently have. ETT stands for exercise treadmill test. DSE is dobutamine stress echo. And MPI is myocardial perfusion imaging. So in any kind of stress test, you'll have your stress modality and then your imaging modality. So the most basic sort of stress test is the ETT, or the exercise treadmill stress test, or the Bruce protocol. And for how often we actually use it, it's always shocking to see how poorly it does in comparison to other tests that we would also order. It has a sensitivity of about 61% and a specificity of 70 to 76. So it really lags behind in terms of the sensitivity, in terms of making that diagnosis, if you compare it to a pharmacologic myocardial perfusion scan, with that sort of clocking in at 81% sensitive. So it will depend, obviously it will depend on your institution and what's available. Sometimes a dobutamine stress echo or a exercise echo is more advantageous because it gives information as to the function of the valves of the heart. We can see in dynamic time, real time, how the myocardium is contracting. Is there a myocardial reserve? Is the left ventricle dilating? We can check pulmonary arterial systolic pressures non-invasively. So the echo actually gives a lot more extra information, but depending on your institution and sort of your resources, it may or may not be available. And then the pharmacologic myocardial perfusion imaging scan, depending on the type of camera that you have, it may be fraught with artifacts. So that's another thing to be aware of. But in terms of pure making the diagnosis, our myocardial perfusion imaging scans and DSEs remain the top choices. So for our regular exercise treadmill test, many of you guys have already heard of this Duke treadmill score, and this is a score that has been validated. It was really more in vogue sort of a few decades ago, but now with the advent of myocardial perfusion imaging, which is a more sensitive modality, this has sort of become less favorable to look at. But the Duke treadmill score is still valuable because it gives a lot of good information in terms of 1-year mortality. So for a Duke treadmill score, the thing to remember is the more negative the number, the worse the sort of study, and such that a very low score, anything less than 11, is a high positive predictor of significant coronary disease, and also a 93.7% chance of multi-vessel disease. These patients at 1 year have a mortality of about 5.25%. And if you remember looking back, we defined high risk as anything greater than 3%. So what this Duke treadmill score basically does is it helps to stratify patients as low risk or high risk. And from there, we're able to better sort of tailor the rest of the diagnostic approach. So that's one thing to remember. On some reports, you will see a Duke treadmill score if you do a basic Bruce review. And the important thing to gain from that is the 1-year mortality. And so for non-invasive risk stratification, again here we see the high risk and low risk and the intermediate risk, the terciles of the stratification. This slide here, the most important thing to take away from this is what the high risk features are. So anyone who has a resting EF less than 35%, which is what we would consider moderate decrement in systolic function, is considered high risk or greater than 3% annual mortality rate. Along with that, again, as we had just discussed, is a high risk Duke treadmill score. Exercise induce LV dysfunction. So if they have a normal EF at rest, and with stress imaging, it drops below 35%, that's a high-risk situation. Obviously, large perfusion defects in multiple territories are also considered high-risk features. Interestingly enough, low risk. So normal, even if you have a stone cold normal study, you are still considered low risk. There's no such thing as no risk, obviously. But a normal study is on par with a small myocardial perfusion defect. And a lot of times, again, if you see a low risk study and the patient really isn't that functionally limited by their angina, that means that there is great utility to considering just medical therapy up front because their annual mortality rate is less than 1%. So they probably wouldn't really benefit from an invasive evaluation with the angiogram and considering stents at that point because their risk overall is so low. So that's the key thing to take away from this slide is that establishing risk from non-invasive stress testing informs the patient's overall prognosis. So in terms of diagnostic coronary angiography, so diagnostic coronary angiography, typically we think of it as a therapeutic procedure, but it has a high utility in terms of making a diagnosis and predicting the patient's ultimate long-term outcomes. It should be ideally used as another tool for stratification of our patients and to help guide decision in regard to optimal revascularization strategy. And again, tremendous prognostic value exists in defining the underlying coronary anatomy, and that's basically proven by this next slide here. So this slide here, there's 3 graphs, and from clockwise, so this top left here are patients who have 1 vessel disease, top right are patients who have 2 vessel disease, and bottom left are patients that have 3 vessel disease. Each of these colored lines represents the ejection fraction of the patient. So yellow is normal, green is moderately to mildly reduced, and gray is severely reduced. Obviously, you can see no matter how many vessels are involved, the patients who have a low EF below 35% have a pretty poor survival long term. And that again sort of denotes that they are high risk for mortality. Remember when we talked about non-invasive risk stratification, an EF less than 35 is a high risk situation. So these patients ultimately, unfortunately, have a very poor overall prognosis. If you look at the yellow line, normal EF, even in 3 vessel disease, if you have a normal EF, your survival, is diminished, but it's not as bad as if your EF, in the case of your EF falls. Once the EF starts to fall, that changes sort of the overall prognosis of the patient. So here, in this case here, you can see that obviously the number of vessels involved does play a role in the overall survival, but more importantly than that, it's really the EF that is the driver, okay? And so doing a coronary angiogram helps to actually sort of define which graph, quote unquote, these patients fall under. And once you define which graph these patients fall under, knowing their EF helps to inform sort of the decision-making process in terms of how aggressive should you be with medical therapy, how aggressive should you be with revascularization strategy. So again, coronary angiography plus an assessment of ventricular function, multimodality approach to risk stratification generates the best data to formulate the best treatment plan for our patients. So this chart here is actually based on CTA imaging. So it actually looks fairly similar to this graph here, which is coronary angiography. So there's been a real move within the field towards risk stratifying our patients based on non-invasive imaging modalities. And primarily that would be a CTA, a coronary CTA. So the coronary CTA is very effective at determining if a patient has coronary disease and to some, and to an appreciable degree of certainty, how bad and how severe each of these vessels are. So again, this here predicts cumulative survival over a period of 2 years. So if your patient didn't want to undergo a coronary angiogram, in certain situations, doing a coronary CTA will provide, just as effective information to make a good decision. And again, it will depend on your institution and whether or not you have access to a coronary CTA. To have a good study, a lot of times patients need to be beta blocked down as to reduce the interference from motion artifact in terms of identifying the blood vessels. So there may be patients that may not be possible, or you may be limited by the resources of the institution. But this is one other thing to consider. So moving on to medical therapy in stable ischemic heart disease. So as with all conditions that we treat, our main goal is really to prevent mortality in terms of myocardial infarctions and prevent overall cardiovascular death. And the second goal is to alleviate symptoms of ischemia. A lot of times, in some of these patients, unfortunately, the EF is poor. It's been poor for a long time. It's a high-risk situation. Addition of medical therapy will help, to improve on paper, their survival. But really what matters most to the patient at that time is really their quality of life and their functionality. So a lot of times making sure that we're treating them appropriately with antianginals, with these classes of medications to help relieve their symptoms of ischemia is really what the patient wants. Lifestyle modifications should be encouraged and reinforced for all of our stable ischemic heart disease patients. And stabilization and management of comorbid chronic illness is essential to the success of secondary prevention in stable ischemic heart disease. And we'll touch on this a little bit more later, but primarily it's really diabetes, as we're starting to see. So in terms of guideline-directed medical therapy, the major classes of medications that we employ include therapy, beta blockade, ACEs and ARBs, mineralocorticoid receptor antagonists, and lipid-lowering therapy. In terms of antiplatelet therapy, the cornerstone still remains aspirin. Aspirin is shown to have a 33% reduction in non-fatal MI, non-fatal stroke, and vascular death in patients who have established coronary disease, with a number needed to treat for myocardial infarctions of 83. So as sort of many of us know, there are still patients who take full dose aspirin, 325, and whenever I see that, I try to sort of explain that the lower dose of 81 is just as effective, with the added benefit of a lower bleeding risk. So a lot of patients will still stay on this 325, and it's always important just to let them know that 325 has no additional benefit, it only carries additional risk in terms of overall bleeding, including intracranial bleeding and GI bleeding. So aspirin, very important in our patients that can tolerate it. Additional antiplatelet therapy, including ADP and P2Y12 antagonists. This includes clopidogrel, Plavix, ticagrelor, Brilinta, or efient, these medications, typically we will see in folks who have already undergone some sort of coronary intervention. And the age-old question is, how long should we continue their Plavix or their ticagrelor or their prasugrel? And there have been a lot of evidence that shows increasingly that if a patient can tolerate being on that, their events overall long-term are reduced, but at the expense of increased bleeding. So a lot of times it really is a personal approach, a personalized approach to these patients. And it ends up being that the patients sometimes who need this the most are our older patients who've had multiple stents, multiple procedures, who represent a high-risk substrate for recurrent events. But also enough, ironically, they're the highest risk for bleeding. So it's always a point of reevaluation over and over again to make sure that the patient is tolerating the therapy just fine. But all of these trials here basically show that DAPT is very effective. As you go from Plavix to ticagrelor, in certain patients, in certain scenarios, there really is no increase in major bleeding. Here you can see in terms of the Pegasus trial here, we did see that in multivessel disease, the MACE and coronary events were reduced for patients on aspirin ticagrelor versus aspirin and placebo. And then in between these doses here, there's really no major difference in bleeding between 90 and 60 BID. 60 BID is approved for long-term sort of management of patients on DAPT. We typically don't see 60 a lot. It seems to really be just 90 BID, but this study showed that there's really no major difference between those two doses. And as of 2012, prolonged DAPT remains a class 2B recommendation. So in certain patients, it is advisable to continue this. In my practice, personally, I will continue DAPT for patients who have multiple stents, stents in high risk areas, including the proximal left anterior descending main stents, and also younger patients. Younger patients tend to have more aggressive disease, and they have many more years in of potential risk for recurrence. So it's always good to make sure you have these patients aggressively managed up front. In terms of beta blocker therapy, beta blockers are the only anti-anginal drugs proven to prevent reinfarction and improve survival in patients with prior MI. So, interestingly enough, these medications are extrapolated off of patients who have ischemic cardiomyopathy. So a common situation you'll see is a patient comes in, they have an MI, and their EF is normal. And so you say, oh, well, would they still benefit from, starting a beta blocker? So for these patients, post-MI patients, we do think that they would benefit from this, and typically it's continued for about 2 to 3 years. Again, it's all about equalizing myocardial oxygen supply and demand, and heart rate is the biggest driver for myocardial oxygen demand. So if we can beta block our patients down, we will help to restore that balance. And even though the patient has been revascularized, they still have this substrate, and especially in the post-MI setting, when they're recovering, I think it's very important to make sure they have beta blockers on board. After 2 or 3 years, if their LV function is normal, then is the time to sort of consider, and they're functional.
Thank you.
Continuing their beta blockade. Situations in which you would consider keeping it longer, 2 to 3 years, include when they have persistent LV systolic dysfunction, or if they have concomitant conditions like hypertension, atrial fibrillation, or persistent angina. But really, the mortality reduction is for patients with heart failure, and that's why we basically use this as a cornerstone for therapy, because patients who have anterior wall MIs typically will have a drop in their EF, and these are the patients, the subset of the patients that benefit the most from being on beta blockade therapy. In terms of ACE inhibitors, again, similar to beta blockade, the populations which derive the largest benefit are those patients who have heart failure with reduced ejection fraction, patients in the acute MI setting, and then our high-risk stable ischemic heart disease patients. So again, really the patient has to, in order to get the biggest benefit, they have to have systolic dysfunction or be sort of in the peri-MI kind of period. Mortality here versus placebo, this is an old study. Obviously, we all know this now, but the mortality benefit in ACE is there, 10.4 versus 12.2%. And multiple studies with low-risk patients, including those with normal ejection fraction and multiple well-controlled CV risk factors who have been revascularized, have not shown a significant benefit with ACE inhibitor. So this is that situation where you have a patient who has no LV systolic dysfunction, they have CAD, they have the risk factors also for CAD, including hypertension, diabetes, and they're stable. These are the patients who there really hasn't been an appreciable benefit shown for them in terms of their cardiovascular benefit. Obviously, these patients may have comorbid conditions like diabetes, hypertension. So these conditions obviously may need an ACE, and their long-term outcomes and mortality would be improved by that. But specifically in regards to our stable ischemic heart disease patients, again, unless they have a lower ejection fraction or are peri-acute MI, they're not going to have this type of mortality benefit. In terms of ARBs, again, these are considered at this point sort of equivalent with ACE inhibitors. They're primarily for patients who are intolerant of ACE inhibitors. As we all know, combination therapy is a no-no and has no significant benefits, only increased adverse effects. One other drug here that I didn't include is the ARNIs, which include Entresto, the angiotensin receptor neprilysin inhibitors. Those have shown the biggest benefit for our patients with heart failure. Studies really haven't shown yet for patients with stable ischemic heart disease, but we know there is a mortality benefit for patients with heart failure. So definitely that's a consideration for post-MI patients who have LV systolic dysfunction and who can tolerate starting an ACE or an ARB. The guidelines will soon shift to recommending ARNIs as the medication of choice for managing heart failure. In terms of our mineralocorticoid receptor antagonists, these are recommended for our acute MI patients with, again, LV systolic dysfunction, diabetes, and or heart failure to reduce CV events. And here again, we can see that all-cause mortality is reduced in these patients. And again, sort of the common thread, it's really LV systolic dysfunction. That's the high risk sort of situation for all of these patients. And that should be a marker of aggressive medical management for all of these patients. So in terms of diabetes and stable ischemic heart disease today, we've seen increasing evidence that diabetes obviously is a very prominent risk factor for stable ischemic heart disease. And at this point in time, it's becoming harder to appreciate that we can control stable ischemic heart disease if we don't concomitantly control diabetes. So the diabetes also has to be managed very aggressively in order for these patients to have the best long-term outcomes. And clinical trials have already demonstrated that improvement in microvascular outcomes, intensive versus conservative controls have not been reflected in CV outcomes. But now we're starting to see that these novel agents, including the SGLT2 inhibitors and GLP-1 receptor antagonists, have a CV risk mortality benefit in patients with diabetes and concomitant CAD. So our SGLT2 inhibitors, basically they work on the SGLT2, sodium glucose-like transporter 2 receptor on the proximal convoluted tubule of our nephrons. And basically what this receptor does is it induces glucosuria. So it absorbs glucose. So when you block this receptor, you allow more glucose to be delivered to the kidneys in the proximal convoluted tubule, and more glucose is exported. It's sort of a dose-dependent kind of effect, meaning that if the patient's glucose is very high, then you'll deliver more glucose to the kidneys and it will work more effectively. So it actually has a very low risk of hypoglycemia because it will not dump more glucose out than it is receiving. So it's actually fairly well tolerated. Our GLP-1 receptor antagonist. So GLP-1 is a peptide that's naturally released in the GI tract after meals. So actually giving GLP-1 in the form of this medication helps to achieve higher than normal levels, which set off this cascade of effects, sort of putting the body into a fed state, thereby decreasing glucagon secretion, increasing our insulin secretion, and delaying gastric emptying to promote satiety. So the SGLT2 inhibitors, the more common ones that we have on the market are empagliflozin and canagliflozin. And both of these have been studied in randomized placebo-controlled trials. And a lot of these medications were initially devised as primary diabetes medications. But as you can see in both trials, a lot of these patients had underlying cardiovascular and a signal was seen in terms of better outcomes for these patients. In particular with empagliflozin, almost half of these patients had a history of MI, half had a history of multivessel disease, and a quarter actually had prior bypass. And so the primary outcome, which included basically non-fatal MI, stroke, and CV death, was significantly reduced for these patients. All-cause mortality was reduced, CHF hospitalization was reduced, and CV death was also reduced. So it seemed, that this medication here, ideally sort of born out to be diabetes, an endocrine drug, actually had very, very positive benefits for our patients with cardiac disease. Also, the same with canagliflozin. Here we can see that with canagliflozin, one thing that's very important here too is this pro-BNP, the NT-proBNP, which increasingly the outpatient BNP has been increasingly associated with prediction of overall prognosis. So with this medication being on an SGLT2 inhibitor, these patients demonstrated a reduction in their NT-proBNP levels at 1 year, which can be indirectly inferred to associate with an improved mortality and overall prognosis for their heart failure. So the GLP-1 receptor agonists, so these medications are also becoming a little bit more popular. The main issue with this is that they are injectables. They have received FDA indication for risk reduction in diabetes patients with ASCVD. I believe the SGLT2 inhibitors have received FDA indication for patients just with ASCVD alone. So even if the patient doesn't have diabetes, they would benefit from being on a SGLT2 inhibitor. And so recently in 2018, there was this consensus pathway that was released by the ACC, which I think is helpful for all of us in terms of deciding if a patient is eligible for being on one of these novel agents. So basically, the first question to ask yourself is, does the patient have diabetes or do they have ASCVD? If yes, then the next major break point is, do they have renal, like end-stage renal disease, pregnancy, or currently breastfeeding? And basically, what it boils down to is if they have either diabetes or ASCVD, then they're an appropriate candidate for either of these medications. In terms of making sure that they have the proper follow-up for patients with underlying renal disease, I would make sure that they're already being followed by a nephrologist, because the patients who would be at the most risk of adverse events are the patients with the lower GFRs. And so those patients you'd want to watch a little bit more closely on these medications. But in terms of a patient who's otherwise healthy, who has only diabetes with some CAD with no renal disease, these are certainly attractive medications to start for them, which would help to improve their cardiovascular mortality. And so again, this hasn't been fully included in management of stable ischemic heart disease, but this consensus pathway is a way to get us all thinking about these newer agents and how they fit in the armamentarium of our management of these patients. And so when I see patients now who have diabetes, who are only on oral hypoglycemics like metformin, and they have coronary disease, I do talk to them about starting an SGLT2 inhibitor and about the benefits of doing so in terms of risk reduction in terms of ASCVD events. So I think those are the perfect patients to sort of have this discussion with in terms of controlling and improving their overall prognosis. In terms of a reference, these two articles here, one's from 2014 and this other one is 2018, the expert consensus. This is basically what the American College of Cardiology has sort of put out in terms of guidelines for managing our stable ischemic heart disease patients, and again, incorporating the newer novel diabetic agents for our stable ischemic heart disease patients. So these are good references. The 2014 one obviously is getting a little dated, and hopefully, the update will be coming out for that fairly soon. And so in terms of, I guess that's my part of the talk there. So for this part, I just wanted to go over what I do and what I offer here, and we'll have questions. I'll open this up for questions on the main topic too. But for everyone who doesn't know who I am, my name is Kenneth Igbalode. I'm one of the new cardiologists here. I started back in August of last year, and I replaced Dr. Nemenich, who'd been here for about, I want to say 25 years. So my practice here involves managing patients with a wide array of cardiovascular conditions, and I can I'm more than happy to help with any of these conditions listed here, or in any way you think I could be helpful to your patients. I'm a very big fan of prevention, and so I try, I'm more than happy to see patients who don't even have established disease, or those who even have a significant family history of CAD in order to get them sort of on the right track. In terms of non-invasive evaluations and studies that we do here, obviously we do EKGs, wearable cardiac monitors, Zio patches, CAM patches for picking up arrhythmias, echocardiograms for evaluation of LV function, and our cardiac stress tests. We have, here at Valley, we have pretty much all of these. Exercise echocardiogram is kind of unclear. We definitely don't have dobutamine stress echo here. We have to send patients to downtown to the U for that one. But we do everything else pretty much here. And here in our office, we do pacemaker and ICD interrogations if there are any questions about the function as well. In terms of diagnostic procedures and interventions, help to take care of cardioversions for patients in atrial flutter or atrial fibrillation, obviously diagnostic coronary angiographies, right heart catheterizations, which in my experience I found actually very helpful for patients who you may have a difficult time discerning their volume status and their creatinine may be going up and down. They may still have symptoms, but you don't know if they're dry or they're wet. So a lot of times a right heart cath will give that extra piece of objective data to help guide your management strategy. Percutaneous coronary interventions, peripheral vascular interventions as well, mechanical circulatory support, which here at Valley we have IABP, and then also insertion of temporary pacemakers. So this is my contact information here. I'm in the Talbot building, 5th floor. Feel free to contact me by cell or email if I can ever be of any assistance. Always happy to also just talk about patients or any curbsides as you guys may need. All right, so that was my talk.